Okay. So the first one, which of the following calcification refers to a calcification that forms in degenerating, diseased, and dead tissue despite normal serum calcium and phosphate levels? The right answer is dystrophic. Also known as frequently resemble an radiograph near the clear space and superimposed form or just off the layers. This is true. Has multiple small capacities. This is true. The third is the promiscuous cartilage mostly differentiated from calcified ectomatous plaque in the carotid bifurcation. This is true. Fourth, the cavities that appear long and off the bone on the radiograph are most likely intraosseous. This is false. And the last one, cyanohydrin changes are there to less calcifications. This is false. Any questions? So welcome to another session, another semester of work. Today we are going to start with the developmental defects of mature and maxillofacial region. This is the first part, and I have one more that we cover next. Can you hear me at that? So these are the learning objectives. You can go over these later. These are the topics that will be covered. I will not be able to cover the entire thing today, but I will talk and do the up to this viscosities. So the coefficient effects are all of you aware of what coefficient effects mean? Any examples? Left, left, right. So the development of the face and the oral cavity, this is quite complex in nature, and it involves many different tissue processes that must fuse, that must merge and fuse in a highly coordinated fashion. So if there is any disturbance in either in the growth of these tissue processes or in the fusion of these processes, that results in coagulation. Yeah, remember when I looked at you? You should have said, no, I'll have to repeat. Okay. So this is kind of a refresher for you guys for the embryogenesis process of the lip and the palate. So there are 6 different things here. If you see the first one, you see a frontonasal prominence. Then you see the green one is the maxillary processes. This is the mandibular processes of the first branchial arch. And then the one in the middle that you see, that forms the future oral cavity. Now coming to this one here, typically the development of the central face, the oral cavity, it starts by the end of the 4th week of embryonic life. Now coming to this B here, so by the 4th week, proliferation of the ectomesenchyme along the nasal placode. So placode is kind of, it's an embryonic thickening or bud-like structure that forms from the ectoderm, and later it gives rise to sensory organs, like in this case, the nasal pits, the nostrils. So that's what is a placode means. So proliferation of the ectomesenchyme from the nasal placodes, this gives rise to these, the ones in the yellow that you see, medial medial nasal processes and the lateral nasal processes. And in the center of these two, you will see nasal pits that later form the nostrils. And then we have the mandibular processes, the maxillary processes, and this is forming the oral cavity. By the 6th week of embryonic life, what you see here, that the ones in the yellow, the medial nasal processes, they fuse with each other and they fuse with the maxillary processes, the one in the green. So when the medial nasal processes fuse with each other, that forms the middle portion of the upper lip. So the mid upper lip, that's what it forms. Whereas the green one, the maxillary processes, they form the lateral part of the upper lip. So in a way, fusion of the medial nasal processes with each other and with the maxillary processes gives rise to the upper lip. Another thing that fusion of the medial nasal processes gives rise to is the primary palate here. And then if we go back to see again, the lateral nasal processes gives rise to these sides of the nose, which is called nasal alley that you see here. This one. So medial nasal processes fuse with each other and with the maxillary processes to give rise to the upper lip. And then the lateral nasal processes, they give rise to the nasal alley, the nasal folds. And this one, the mandibular processes give rise to the mandible. So at the same time, maybe by the end of the 6th week of embryonic life, now you see a primary palate here that came from the fusion of this yellow portion, the medial nasal processes. But we also see the secondary palatal shelves. They start to form in this time. So secondary palatal shelves, initially they are positioned in a vertical position, like they are vertically oriented along both sides of the developing tongue. But then later, what happens as the mandible grows, the developing tongue, it drops down. And that gives the palatal shelves the opportunity to rotate in a horizontal position, and then they start approaching each other for fusion. And this happens by the late, say, 7th to 9th week of embryonic life, when these secondary palatal shelves, they approximate each other, they fuse, they also fuse with this primary palate, they also fuse with this nasal septum. So that fusion of the secondary palatal shelves, it starts from the anterior side, from here, and then it progresses towards the posterior. And this fusion is completely formed by about the 12th week of embryonic life. So clefting, orofacial clefting, this is one of the most common form of major congenital defects. We very commonly see cleft lip, cleft palate. So what gives rise to cleft lip? So when there is defective fusion of the medial nasal process and the maxillary process, that is when cleft lip arises. What gives rise to cleft palate? Cleft palate is when there is failure of the palatal shelves to fuse. That gives rise to cleft palate. Now these are some pictures of the orofacial clefts. You see a cleft lip here. This is cleft palate, so this is normal. This patient, they don't have a cleft lip, they have only cleft palate. Here, this child has both cleft lip and cleft palate. And the one that you see here, what do you think of this? What kind of clefting is this? Cleft? Unilateral, okay. So the cleft lip is categorized into different types, 3 different types. One is complete clefting, incomplete clefting, but there's another subtle type of clefting of the lip, which is called microform type of clefting. So in the microform clefting, you will not see an obvious cleft, but it will appear more like a notch in the, in the lip or in the vermilion border of the lip. So it's the musculature, the lip musculature, you will not see any clefting in that. So about 45% of the cases, they comprise of cleft lip with cleft palate. So the patient has both cleft lip and cleft palate. About 30% of the cases, they represent isolated cleft palate without any clefting of the lip, whereas 25%, they represent isolated cleft lip only. Uh, Now, the etiological factors of cleft lip and cleft lip with cleft palate are quite identical. They are quite similar. That is why they are considered a separate entity from cleft palate only. Now, up to 30% of patients who have cleft lip with or without cleft palate, and about 50% patients who have cleft palate only, they often have associated anomalies. And these may be, syndromic conditions, or they may be isolated anomalies like congenital heart defects, urinary tract infections, or things like hydrocephalus. So when we talk of syndromic conditions, they may either be single gene syndromes that have, say, autosomal dominant, autosomal recessive, or X-linked pattern of inheritance, or they may arise because of some chromosomal anomalies. Now, few risk factors that are associated with orofacial clefting. So maternal alcohol consumption. If a mom consumes alcohol while she's pregnant, that increases the risk for developing clefting of either cleft lip or cleft palate or both. Maternal cigarette smoking, so smoking in pregnancy, that almost doubles the risk of uh, having any kind of clefting in the child. Another um, factor that has been listed is if a mom is on any anticonvulsant therapy, for example, phenytoin, that increases the risk of clefting by almost 10 times. But there's another factor, say if a mom, pregnant mom, is taking folic acid, supplemental folic acid, and many times, or many moms, they may be on, folic acid, that can reduce the frequency or the prevalence of clefting in the child. Now, racial and gender variation, so considerable variation has been reported in these clefting anomalies. So the highest frequency of cleft lip with or without cleft palate has been reported in Native Americans. Highest frequency about 3.6 of 1,000 births. This is followed by the Asians who have at least 1.5 times higher risk than in white population. And then the lowest frequency has been reported in African American population. Now, the cleft lip with or without cleft palate, this is more commonly seen in males than in females. And it is said that the severe the defect, the higher the prevalence in males. Isolated cleft lip, male is to female ratio, slightly higher prevalence in males compared to females for isolated cleft lip. And then for cleft palate only, this is more commonly seen in females. Now, coming to the cleft lip, so 80% of the cleft lips are unilateral. You will see them on one side only. And the ones that are unilateral, they often occur on the left side. 70% of the unilateral cleft lips you will see on the left side. 70% of the unilateral cleft lips will be associated with cleft palate. So it will be a cleft lip with cleft palate kind of presentation. Whereas 85% of the bilateral cleft lips are seen with cleft palate. So there's a higher frequency, higher chance of cleft lip to be seen with cleft palate if a patient has bilateral clefting of the lip. Cleft palate, so there is a complete cleft palate, there's an incomplete cleft palate. Sometimes you will see cleft palate in the interior, like in the primary palatal area, where you will see some clefting, which is anterior to the incisive foramen, and it extends to the alveolar ridge. And in the complete kind of clefting, you will see clefting that involves both the hard palate and the soft palate, and you will see it posterior to the incisive foramina. Now, the minimal manifestation of a cleft palate is a bifid uvula, like you see here. This is the most subtle, presentation of a cleft palate. And the prevalence of this bifid uvula is higher than cleft palate. Another kind of clefting that you may see, this is called submucosal cleft palate or submucous palatal cleft, and this is what it looks like. So you will not obviously see any kind of clefting in the palate, but you will see an indentation like a V-shaped and indentation on the palate, which is because there is clefting in the musculature, in the muscles of the soft palate, but there's no clefting in the bone. The clefting does not extend to the bone. That's why you see this kind of submucous cleft palate. And in this patient, you can also see a bifid uvula here. This is an example of unilateral incomplete cleft lip. So the incomplete cleft lip, it affects the lip area only. It does not extend all the way to the nostril, to the nose or the nostrils. This is unilateral complete cleft lip. So you can see the clefting extending from the upper lip all the way going through the nose, nasal septum. So what kind of clefting is this? Bilateral, complete or incomplete? Incomplete cleft lip. Bilateral, incomplete cleft lip. Bilateral, complete cleft lip. So this is extending to the nasal area, to the nasal septum, to the nostrils. This is a complete cleft lip. And the third, the most subtle one I showed you on the first slide, that's the microform cleft lip. This is example of cleft palate. You can see it, this is affecting both the hard palate and the soft palate. And this patient has cleft lip also. So the treatment for these orofacial clefts, this is quite challenging, and it requires a multidisciplinary approach. So specifically, it involves a pediatrician, a pedodontist, oral surgeon, speech pathologist, right, a plastic surgeon, orthodontist. So all of these, they have to work as a team. Now the patient may require number of different procedures depending on the severity of the defect, how deep the clefting is, what is the extent of the clefting. But typically for the primary closure of the lip from cleft lip, this is usually done during the first few months after birth. It can be done right after birth, but it's better to wait until 2 to 3 months. And then it is followed by repair of the cleft palate if the patient has cleft palate also. So the rule of tens is based on, this comes from two oral and maxillofacial surgeons who coined this rule of tens for a cleft lip surgery, and they recommended that it's ideal to wait for surgery for a cleft lip until the child turns 10 weeks of age, that they are 10 weeks old, they weigh at least 10 pounds, and they have at least 10 grams of hemoglobin. That's for the cleft lip. So that's about, say, 2 to 3 months after birth when the cleft lip surgery is done. Then for the cleft palate surgery, it's ideal to wait anywhere from 7 to 15 months of age to do cleft palate surgery. And this is an example of a cleft repair of cleft palate. So this patient has cleft palate, they have cleft lip also, and this is after the surgery. So definitely genetic counseling is required for the parents. And if a patient, like say, for orofacial clefting, about 3 to 5% risk for, for siblings or offsprings of unaffected people that they will develop orofacial clefting. That is if they do not have any syndromic conditions, if they do not have a first degree relative who is affected by the clefting. Whereas if there's a first degree relative who also has orofacial clefting, then the prevalence increases to 10 to 20% for these patients. And this is even higher if this is associated with syndromic conditions. So there are many syndromes which have, in which the patient will have cleft lip, cleft palate, or both of them. Any questions? Okay, coming to the next topic, commissural lip pits. So these are small mucosal, these are kind of invaginations that you can see at the corners and the commissures of the mouth, and they look like, indentations or small pits in the corners of the mouth. And these may represent a failure of fusion of the maxillary and mandibular processes. So when they fail to fuse properly, these pits may arise from that uh, process. Commissural lip pits, these are more commonly seen in adults. You may see it only on one side, or the patient may have on both sides. So typically, these are not associated with any syndromic conditions. Well, if a patient has somewhat deeper pits, and if you try to squeeze them hard, you may find some secretions from the minor salivary glands, but otherwise no treatment is needed. These are incidental findings. Most of the time, the patient does not even know they have, but when you start clinic and start doing thorough head and neck exam, you may be able to find them. And these patients, well, it has been reported in some studies that these patients may have a higher prevalence of preauricular pits, means pits in front of the ears, but that does not have any relevance to any kind of syndromic conditions or any clinical significance. So these are examples of the commissural lip pits. So you see those indentations at the corner of the mouth in the commissure. This is another one. Paramedian lip pits, so these are similar indentations or invaginations, but you will see these on the lower lip, and these are believed to uh, uh, arise as persist. So on the lateral lip during the embryonic life, not the lateral lip, on the lower lip during the embryonic life, there will be some kind of sulcus or fissures, which typically they should fuse by the 6th week of embryonic life. But if they fail to fuse completely or they persist, that can give rise to paramedian lip pits. So they can appear either bilaterally. Typically, what we see are bilateral in the books or in the literature, but the patient may have one like in the center of the middle lower lip or on one side of the midline of the lower lip. Similar to commissural lip pits, if you squeeze them, sometimes you may be able to find secretions from the salivary glands. But what is most significant about these paramedian lip pits, that these are associated with a syndromic condition that is called van der Waals syndrome. So they have autosomal dominant pattern of inheritance. The patient will have cleft lip with or without cleft palate with these paramedian lip pits in the van der Waals syndrome. And these are what they look like. So they may appear like deep indentations. Some of them, they may look like hump, like, clinical expression in the middle of in the center of the lower lip. That's why they are called paramedian lip pits. This is another example of paramedian lip pits in a patient with van der Waals syndrome. So he has paramedian lip pits, and this is the same patient who also has cleft palate. And for aesthetics or for any kind of functional reasons, they may be excised, but otherwise you don't have to excise those paramedian lip pits. But definitely the cleft lip and the cleft palate, they are more challenging to treat and they need to be treated first. Double lip is like a redundant extra fold of tissue that you see on the mucosal side of the lips. More commonly, you see it with the upper lip, but there have been cases reported affecting both the upper and the lower lips. Now, more commonly, it is congenital, but some cases they may arise later in life, so they may be acquired. And the most common example of an acquired double lip comes with Usher syndrome. So in Usher syndrome, the patients will have double lip. They will have drooping of the eyelids, more commonly, drooping of both eyelids, which is called blepharochalasis. And then 50%, up to 50% of these patients may have enlargement of the thyroid gland, which kind of does not affect the function of the gland, but it's just, the thyroid gland it becomes bigger in size. Now, other reasons of acquired double lip, patients may develop if it can arise from trauma or from oral habits such as sucking on the lip that can also give rise to that extra fold of mucosal tissue that a patient may have either on one or both lips. Severe cases may be excised. This is example of the double lip. So typically when the patient smiles or when the lips are tensed, that's when you will see that redundant fold of tissue. And if the lips are closed, then you may not be able to see it. This is blepharochalasis, so drooping of the eyelids, recurrent edema of the upper eyelids. It causes sagging of the eyelids, and sometimes it can be to an extent that it impairs the vision also. So in such cases, yes, surgical procedure will be needed to, get rid of the edema and the to repair the drooping eyelids. Fordyce granules, have we done this last semester? Anyone remembers? Have we done Fordyce granules? So you may see Fordyce granules and hairy tongue in this topic again. I'm going to briefly go over these, but still cover them. So Fordyce granules, we know these are ectopic sebaceous glands. Ectopic because these are not meant to be in the oral cavity. These are structures of the skin, cutaneous structures. But when you see something out of its normal place, you call it ectopic. So these are more commonly seen in the buccal mucosa and in the vermilion border, especially of the upper lip. Other places are the retromolar area and the anterior tonsillar fossa. They present like multiple white or multiple yellow or yellowish white kind of papules in the oral cavity. Typically, the clinical presentation is diagnostic and you don't need a biopsy, but we have seen biopsies come in for Fordyce granules also. Sometimes the patient may be concerned and they may request their dentist or surgeon to do a biopsy. So this is example of Fordyce granules. And these are on the lip, multiple yellowish papules on the upper vermilion border of the lip, multiple clusters of yellowish papules. So if I see something like this, sometimes, a person who's not very familiar with these, they may be concerned and you may end up doing a biopsy. Another example of Fordyce granules on the buccal mucosa. More Fordyce granules on the buccal mucosa, multiple yellowish clusters of yellowish papules. So on the slide, we see, multiple sebaceous glands. So because these are sebaceous glands that secrete sebum, so see multiple lobules of these whitish sebaceous glands, and these glands typically they will contact the surface through a duct. So this is a duct that is opening into the surface to secrete sebum. Macroglossia, so macro means big, glossia is tongue, so enlarged size of the tongue. There can be different reasons for having macroglossia. There are many congenital conditions that can give rise to enlargement of the tongue. There are many acquired conditions. And the most frequent causes of a large tongue, vascular malformation and muscular hypertrophy. Can you think of any examples of vascular malformation on the tongue that can make it look bigger? Angioedema, that's not a vascular malformation, that's an allergic reaction, right? But yes, that angioedema is one of the reasons for macroglossia, but you can think of things like lymphangioma or hemangioma. So those are vascular malformations, and if a patient has on the tongue, that will result in macroglossia. Muscular hypertrophy, so when can the tongue muscle become hypertrophic? So think if a patient, adult patient who's edentulous, what happens to the tongue if they don't get any dentures? Edentulous patients, say edentulous for about 10 years now, then the tongue musculature that starts to hypertrophy, multiply, proliferate the muscle fibers, and the tongue can become big. It can be difficult to contain the tongue in the oral cavity sometimes, and then if they try to get dentures, they may not, remain in the mouth well. So most commonly, macroglossia affects the children. But when a patient has a large tongue, the pressure of that tongue against the mandible or against the teeth, because now the tongue is pushing continuously against the teeth and the mandible also, that can result in this kind of crenated, lateral crenated borders of the tongue, which represent the embrasures between the teeth. And as a result of that continuous pushing of the mandible, that can also result in mandibular prognathism. So the mandible can move forward over time. It can result in an open bite also. Now, the treatment of macroglossia, it really depends on, what is causing the macroglossia. Sometimes treatment of the underlying condition will take care of the macroglossia, and it also depends on how severe the condition is, because mild cases may not need any kind of treatment, whereas severe cases, they may have to do a kind of glossectomy, reduction glossectomy in those cases. So vascular malformations, these are the congenital and the hereditary causes, vascular malformation. Then we have, so this is a patient who has hemangioma here. Hemihyperplasia. Hemihyperplasia is something like this, where half of the face, so half the tissues and the bone and sometimes the teeth also, they start to grow bigger, affecting only one side of the face. So hemihyperplasia. So you see there's growth on the right side, and this is the same patient, and you can see that the tongue is becoming bigger on the right side only compared. So that's where the normal tongue ends. So that's affecting the right side. Then we have cretinism. Cretinism is children who are affected with, say, congenital hypothyroidism. So in those with hypothyroidism, there is continuous deposition of products like glycosaminoglycans. They get deposited in the soft tissues, including the tongue, and that can increase the size of the tongue. And then we have some syndromic conditions, Beckwith-Widman syndrome, Down syndrome, that's common. And then things like if you remember the MEN2B, multiple endocrine neoplasia type 2B, also sometimes with patients with neurofibromatosis, NF type 1, they can also have macroglossia. This is a patient with macroglossia, Down syndrome. So usually patients with Down syndrome who have macroglossia, the tongue appears more papillary, more fissured. And sometimes, the tongue may be so large that it's difficult to close the mouth. So if the tongue is continuously exposed to the outside environment, it can become necrotic, it can become ulcerated. There can be, secondary infections like candidiasis that can affect the patient. And in severe cases of macroglossia, it can lead to obstructive sleep apnea. That can cause sleep apnea also. Now, these are the acquired causes of macroglossia. In edentulous patients, muscle hypertrophy can cause enlargement of the tongue. Mixed edema, so mixed edema is the same thing, hypothyroidism in adults. Deposition of glycosaminoglycans in the soft tissues can increase the size. Amyloidosis, so if there is deposition, either localized deposition of amyloid material, or because of a patient has multiple myeloma, they can have amyloid deposits in different parts of the body that can increase the size of the tongue. Acromegaly, increase in growth hormone, then it can lead to increased size of the tongue also. Things like angioedema, allergic reaction, when, say, for example, patient takes a medication, they have rapid swelling of the lips and the tongue, that can cause macroglossia. Then any cancers, any tumors that affect the tongue, they can increase the size. This is an example of large tongue, secondarily infected, ulcerated, because if it is big enough that it is not contained in the oral cavity, then this is what can happen. It can become ulcerated. The patient will have, definitely they will have candidiasis on the tongue. Okay, lingual thyroid. Any questions until now? Okay. So lingual thyroid, by about, I would say, the second or no, third or fourth week of embryonic life, the thyroid gland, it begins as an epithelial proliferation in the floor of the pharynx. Pharyngeal gut means the pharynx. So in the pharyngeal floor. And by about the seventh week of embryonic life, the thyroid gland, it normally descends into neck to its final resting position, which is anterior to the trachea and the larynx. And the site where it later invaginates, that is called the green one that you see here, foramen cecum. So foramen cecum is at the junction of the anterior two-thirds of the tongue and the posterior one-third of the tongue. If for any reason this primitive thyroid gland does not descend normally, then thyroid tissue may be found between this foramen cecum, between this green dot, and what is this here? Does anyone know what this is? Epiglottis. Epiglottis. So then if the primitive gland does not descend in a normal way, then thyroid gland can be found deposited between this foramen cecum and the epiglottis. Now think if it is not found in its normal place, it is called ectopic thyroid gland. And 90% of the ectopic thyroids will be found in this place between the foramen cecum and the epiglottis. And these are called lingual thyroids. Do you know what that is? Have you ever seen it in the mouth? You have?
My son got sick and he opened his mouth and that popped up and I took him to the doctor because I thought he was dying.
So I've seen in two patients, and this patient was kind enough to let me take a picture because I was excited when I saw it. And and I was doing a head and neck exam, and I asked her to do the to look into the throat, and this thing popped up, and I was so excited. I said, "Let me take a picture. I need to show." So this is the foramen cecum will be somewhere here at the junction of the anterior two-third and the posterior one-third of the tongue. So the lingual thyroid can be seen anywhere from here to that epiglottis. And this is an example of lingual thyroid. Well, the size depends what the size of the lingual thyroid is. Some of them can be big enough to obstruct the airway, and some of them may have symptoms also. But these are, you see all those blood vessels, those capillaries on top of that. So these are quite vascular structures. These are quite, if you have to biopsy them, you have to be careful because of the risk of hemorrhage. So about 10 to 20% of patients, they often have these, asymptomatic remnants of thyroids on the tongue, on other parts of the body. But most of these, they are asymptomatic. And some patients may have symptomatic, thyroids, and most commonly depends on the size of the thyroid gland. But some of the common symptoms are things like difficulty in swallowing or shortness of breath, or they may have, voice changes in the voice because of that. So 4 to 7 times, these are more frequent in females, probably because of hormonal changes in the females that occur more often than males. And in about 97% of the cases, the ectopic thyroid is the only thyroid tissue they have. So up to 70% of these patients have been reported to have hypothyroidism. So it is believed that the ectopic lingual thyroid is kind of a reactive or a secondary phenomenon to that hormonal hypofunctioning of the thyroid gland. And these are most common symptoms are dysphagia, dyspnea in patients who have symptoms with these. So the diagnosis is determined by thyroid scan using either iodine isotopes or things like technetium-99. And in this image that you see on the right, so this is an iodine isotope that you can see the uptake is more in the tongue area, and there is minimal uptake in the neck area where the thyroid is supposed to be. So biopsy should usually be avoided because these are highly vascular structures. There is risk of excessive bleeding. But sometimes you have to do a biopsy if you are suspecting other kind of tumors or malignancy. So you can do an incisional biopsy, or sometimes that may be the only functioning thyroid tissue that the patient may have. And if you have to excise it for some reason, literature also suggests auto transplantation of that thyroid to some other part of the body, so the patient has some functioning thyroid gland. So for asymptomatic lingual thyroids, usually periodic follow-up, that is the recommended treatment. But for patients who have symptomatic thyroids, either suppressive therapy with supplemental thyroid hormone that can reduce the size of the thyroid gland if they have large. And if that does not help, then surgical removal of the thyroid and auto transplantation to some other part of the body. Malignancy has been reported in about 1% of these ectopic thyroids, like lingual thyroid carcinoma. But the lingual thyroid carcinoma is reported to be more common in males than in females, whereas females are reported to be more likely to have the ectopic thyroid. So it is recommended that in males who have ectopic lingual thyroid, it should be taken out for preventive reasons after 30 years of age. Fisher tongue. So Fisher tongue, I guess we have somewhat covered last time, so I'm going to go over it quickly. So Fisher tongue, the tongue will have fissures, multiple grooves that you will see. There's a strong association with geographic tongue, and to the extent that studies also suggest that geographic tongue may cause Fisher tongue. So ask the patient to clean the tongue completely, because deposition of any food, any debris may, may irritate the tongue, or it may be a good place for any kind of organisms to thrive, especially fungal organisms. So this is an example of Fisher tongue, multiple fissures and grooves. Another example of severe fissuring of the tongue. Then in other cases, the fissuring may be so severe that it almost, divides, or uh, it looks like, multiple islands that you see on the tongue. And this patient may have somewhat dry mouth also. Remember that triad, Melkerson-Rosenthal syndrome? So this Fisher tongue is a part of this syndrome also. So patient will have Fisher tongue, they will have paralysis of the facial nerve, they may have facial swelling or lip swelling with this. And this is a patient with that syndrome. They have incompletely closed eye, they have drooping of the lip on that side, so they have somewhat swelling of the lips also. Hairy tongue, I guess we have done that too. Let me see how much time we have. So hairy tongue, possible causes, poor oral hygiene, or if patient is on some medications that are causing dry mouth, or if they have had head and neck radiation that can cause xerostomia, or there may be excess growth of the excess accumulation of keratin on the filiform papillae, or either there is reduced desquamation, cleaning of that excess keratin. That is what causes hairy tongue. This is an example of hairy tongue. You see hair-like filaments on the dorsal surface of the tongue. They can grow to such an extent that they almost look like they have a thick, matted kind of clinical appearance. So what do you tell the patient? How do you treat it? If we have done it, you should remember, right? How do you treat hairy tongue? Any recommendations for the patient? Huh? What else? So if a patient is a chronic smoker, cut down on the smoking, increase water intake. So, because if they have dry mouth, the water, it kind of helps with cleaning the tongue. Tell them to clean the tongue with a tongue scraper, right? Those kind of things. Typically, these are patients, they do not have any problems, but some of them may complain of foul breath, or for aesthetic reasons, they may come to you for treatment of this hairy tongue. That's another example. It may look more yellowish, brownish because of the accumulation of pigment producing bacteria or pigment coming from the foods or drinks. This is coated tongue. So sometimes you may not see the hair-like, elongation of the filiform papillae, but this may often be confused with candidiasis, and the patient may be put on unnecessary antifungal therapy. So keep in mind this is only coated tongue, and you ask the patient to clean the tongue with a tongue scraper or brush the tongue. Then sometimes patients may have this kind of transitory, transient staining, black staining of the tongue. This is for patients who are on some kind of, say, medication, especially Pepto-Bismol for upset stomach. So this is bismuth staining. So the medication contains bismuth subsalicylate, and our saliva contains trace amounts of sulfur. So the bismuth in the medication, it reacts with the sulfur to form bismuth sulfide, and that gives the black color. But discontinuation of the medication will resolve the staining. Varicosities. Varicosities are dilated tortuous veins that we see in the back of the legs. We see also in the oral cavity. These are commonly seen in older patients because of the weakening of the blood vessel walls and then loss of tone in the surrounding connective tissues, which causes dilation of the veins or the blood vessels, leading to varicosities. So sublingual varicosities are the most common type that you will see in the oral cavity in old patients, patients typically who are over 60 years of age. Clinically, they look like multiple bluish purple kind of lesions in the mouth, somewhat like this. So this is on the ventral side, on the underside of the tongue. And this is what they look on the legs. So there was one study that suggested that people who have higher varicose veins on the legs, they also have increased incidence of sublingual varicosities. But then other factors that have been suggested to be associated with these varicosities are things like cardiovascular disease, a history of smoking, or hypertension, or patients who have cirrhosis, liver cirrhosis. They tend to have increased incidence of varicosities. These are usually asymptomatic. Patient will not have any symptoms, so these are examples of sublingual varicosities. Sublingual because they are on the underside of the tongue, so sublingual. Now there are also, you will often see solitary varices on the lip or on the buccal mucosa, but again in older patients. And this is, they often become noticeable when the blood in those blood vessels tends to thrombose. That is when they clinically become noticeable. So these are often firm, non-tender. They look bluish from the blood that is in the blood vessels. Typically, no treatment is needed, but some patients, for aesthetic reasons, they may want them taken out, especially if they are on the lips. So these are to rule out other conditions. This is an example of a solitary varix on the lower lip. These are multiple of these on both the upper and the lower lip in an old patient. Any questions? Okay, thank you.